Today we have Dr. Amy B. Killen, a leading physician in regenerative and hormone optimization medicine. She specializes in women's health and helping patients navigate their queen phase with evidence-based interventions. A board-certified emergency physician turned longevity specialist, she combines cutting-edge treatments like stem cell therapy, hormone optimization, and peptides with practical lifestyle wisdom at her Utah and Texas clinics. She also shares her expertise through international speaking engagements and educational content creation. As founder of the Human Optimization Project, Dr. Killen continues to advance the field of longevity medicine with her Rage Against the Mainstream approach. She lives in Salt Lake City with her family of 5. Let's listen to her truths about hormone replacement therapy in today's episode. Well, as I said, I really appreciate you taking time with me today. I love your message, and I just, it resonates, all of your posts and your information. It's so helpful, and it's something that premenopausal and menopausal women don't hear.
Yeah.
Tell me a little bit about your background and how you got into this field of medicine.
So I was an emergency physician first. So I did my ER training in emergency medicine. And then I worked another 7 years in Austin in a really busy emergency department. And towards the end of that, like the last couple of years, so I have 3 kids. I had my 3 kids within 2 years. So I had twins and one more, all within 2 years. And towards the end of that, my husband ended up moving out of state for a job. So I was kind of the lone caregiver to these 3 kids who were like babies. And I had to be at work in the morning at a job that started at 4 in the morning. And so, I did this for a little while, sleeping 3 hours a day, eating garbage, never exercising, kind of always like on the edge of like sanity. And it was taking its toll. And I remember kind of one day I was in the ER and I was looking out at everyone waiting to be seen, with their kind of chronic medical problems. And I just realized that if I didn't make some changes in my life, I was going to be one of those people, with a chronic medical problem that probably could have been prevented if they had education and resources. And so that was kind of a light bulb moment. And this was in 2012, sorry. I just realized that I needed to learn some new things. I needed to learn how to be healthy. I needed to figure out how to make other people healthy. And so I left emergency medicine and began pursuing hormones and longevity medicine and health optimization and kind of all these words we talk about now.
Right. Exactly. It's funny because I do think a lot of emergency physicians get into this longevity field because they see a wide array, of the population, all different ages, all different stages of health. And that presents an interesting look at our population and the health that we either have or do not have.
Yeah. And I think that, we also see just the people who, unfortunately, the system has failed. They keep coming back. They've got severe diabetes and they've been in the hospital 4 times and you're seeing them for the 5th time. And, we do a good job in medicine of treating traumas and of treating acute problems, but we do a pretty bad job of preventing disease and keeping people healthy, actually.
It's so true. And I say that about insurance all the time too. Insurance is not around to keep you healthy. Insurance is there to treat your disease. And we need to get back to that, keeping people healthy rather than treating disease. We need providers who treat disease, of course.
Yes, absolutely. Yeah. If I get into a car wreck, I want those ER doctors to be there and be doing the job that I did for a long time. But they're not as good at keeping people out of the ER, frankly.
Right. And of course, the ER is just not the environment where you're going to talk to patients about healthy lifestyle and how can we improve your longevity. Yeah. You're there to solve a problem. And I know that, we could talk about the abuse of the emergency room and how patients don't have access. They use it as their doctor's office. Yeah. That is the goal of the emergency room, to just take care of the problem at hand. So really, it's physicians who want to be passionate about this and learn more and take the time to educate their patients about what can we do outside of taking medicine to
exactly
as we age. Excellent.
Yep.
So I know that both you and I talk about hormone replacement all the time. And some of the things that I get a lot of questions about is what's the difference between natural and synthetic? And does that matter from the body's standpoint?
Yeah. Yeah. So I like to use the term bioidentical or body identical more than natural, because I do think that the natural industry is a little sort of trying to brainwash people. What really matters is what the chemical structure is of the hormone. So we want to take in hormones that are chemically identical to the hormones that our body already makes in terms of estrogen and progesterone and testosterone, but mostly the estrogen and progesterone. And it does matter because we have seen in studies like the Women's Health Initiative and others that when you use these synthetic versions of hormones, which are, they're similar, like they still react to the receptor, but they're like, they have like a growth off their head. They're like a little bit, like they're like a little wonky. Those versions of the hormones, especially the synthetic progestins, really cause a lot of problems. And so we've gotten back in the last 20 years or so to thinking, well, maybe if we just use the hormones that look like the hormones my body makes, that are identically the same chemically, then that would be better. And it does turn out that these hormones, the original source of the hormones that we're using are, yams and soy and cactuses and things like that. But the source isn't really what matters. What matters is what happens when it gets in your body.
Mm-hmm. Exactly. And that goes to how the hormones work in our body. So the hormone has a chemical structure and it has to attach to its receptor. So both bioidentical and synthetic hormones do attach to the receptor, but in a slightly different way if they have a funny little thing hanging off it, something chemically that looks a little different, which means we may get some of the benefits of the hormone, but we may get some unwanted effects.
Yeah, exactly. These receptors are they're very complicated. I've been reading, I'm writing a book and I've been reading about them. And, I think of in my head, I think of like a lock and a key. Like we talk about the lock and the key, but you have the lock and the key and it's just this one thing. But really these receptors are, they're always changing and morphing and they have different like ways that they can exist in the world. And it's fascinating. So the idea that just putting an extra thing on a hormone would change the whole series of events. It makes sense when you understand sort of the fluidity of the receptors. They're not just these static things that just sit there and wait for the estrogen to come to them.
Right. That's really interesting, actually. And I think most people don't realize the importance of the receptor. Our receptors change too as we age, right? The number of receptors we can have can go up or down, and the receptors can become damaged over time.
Yeah. And even like, there's also the other thing we can't measure is we can't measure what happens after the estrogen binds the receptor. We can measure your estrogen level, and that's a piece of information and I think is important, but we can't measure how many receptors you have, like you said. We can't measure how sensitive they are to estrogen. We can't measure what happens after estrogen binds and you have a series of events inside the cell or inside the nucleus of the cell. So there's a lot of things that we can't measure, and some of that may play into why, levels of hormones can be helpful. They're a good starting point, but, your level of estrogen of 70 may make you feel great where someone else feels horrible. Like everyone has such different sort of optimal levels. And a lot of it, because we probably don't know what else is happening with them.
That is so true. I talk about that all the time, is that a big missing piece of our information is how the hormone gets into your cell. And I say hormones floating around our bloodstream do nothing. I mean, that's what shows up in our blood value, and we can see how much estrogen, how much testosterone, but that doesn't actually tell us about the end output of the hormone, which is it turns a cell on to do a job or to replicate or whatever the message is that the hormone is carrying.
Exactly. Yeah. We have so much to learn. Like, I think that we're just at the very edge of understanding all of this. Certainly we understand enough to get started and to get women on hormones. I think we're both big fans of it. But there is so much more to learn, and hopefully we do over the next few decades.
Yeah, I hope we get a lot more funding for that because we need it, definitely.
It's not looking good, actually. So
I know it's not. But if we keep talking about it, we'll keep it hopefully in the forefront because I think in, who knows, 50 or 100 years, we may look back and look like we're practicing in the dark ages right now, but really we're practicing with the information that we have at hand. Just like we people in our past 100 years ago and think, oh, it's crazy. They put leeches on you, to suck out the bad humors. But that was the information they had at that moment.
Yeah, exactly. Yeah.
Right. So I agree. I think the bioidentical or body identical, I know that you are fond of using, is at least we know that the bioidentical hormone will function at the receptor the same way the hormone that your ovary makes. So we don't have to worry about any differences there. So then how did synthetic hormones get so popular?
I don't know. They're made by a pharmaceutical company, and it was in the 30s or 40s that it was first discovered that you could get this pregnant mare's, urine, which was Premarin, came from pregnant mares. I think it was the 30s that they first discovered it. That this would actually, you could take this urine and give it to a woman, idea was this? This is actually a real person. They take this urine, give it to a woman to see if it helps with her menopause symptoms. And it was like, oh, it turns out it does. And then, of course, the problem became like, well, how do we make this on a large scale? And then you have to make, it's thousands of gallons of this urine. It's very sad. Around the same time period, in the 30s and 40s, they actually did discover that you could get estradiol directly with a little bit of modification from soy and yams. And it's interesting because those two things happened at the similar time frames, 30s and 40s. But for some reason, the Premarin took off, and it just must have had more funding versus the bioidentical form of estradiol and progesterone didn't as much.
Right. And, if you look at a lot of the national guidelines, they are very fond of making sure that providers are not making false claims that bioidentical hormones are safe and synthetic hormones are unsafe. And I don't think anyone is saying that it's that black and white, but I think the most important thing is to recognize there is a difference between these two hormones, and we can't apply research using one type of hormone to all the types of hormone in that category.
Yes. And I think it goes both ways. I mean, I think, unfortunately, a lot of the research that we have is in the synthetic versions of the hormones. And, a lot of the positive benefits that we've seen with, for instance, heart disease benefits are with oral Premarin. And we do have other studies on oral estradiol, but we don't actually have a lot of good studies that transdermal estradiol reduces heart disease. And it very well it may, but I do think that we have to be careful in both regards, saying it matters the structure of the hormone. Is it bioidentical? Is it synthetic? And it also matters the route of the hormone, because taking it through the skin versus orally, does change some things. And so we have to study all of those things, and we can't, kind of just assume anything.
Right. I know. I mean, it sounds like you are as well. I'm so data driven. I like to be able to say to patients, here's what the data shows and the risks and the benefits, and we can prove this repeatedly in studies.
Yeah.
But we don't always have that answer for every single question about hormone replacement therapy. So once again, you got to go with what information we have today. And I think even though most of the information on synthetic hormones that we do have, it is the volume of data, I'm always impressed at, yeah, it actually is not bad at all, because hormones get such a bad rap.
Yeah.
I do think there are some side effects. There are things that we can do better, certainly areas we can do better. But even the conjugated equine estrogens, the Premarins, really were the ones that showed so much improvement and reduction in disease and things. So we can't just kind of, put them
it's easy to villainize them. I totally agree. I think it's easy to villainize them. But, they did increase your blood clot risk by twofold. Right. But if you also think about it, that was, 17 versus 34 women per 10,000 who got blood clots. So yes, it's a twofold increase, but like really small numbers. Overall, right? And so the things like that, like, little bit of a stroke increase, little bit of a heart disease increase in late starters with synthetic Premarin. But again, like such small numbers compared to the benefits. And so I totally agree with you on that. We have to be very careful about what we take from those studies and then use. We can't just take the good stuff and then, and not the rest.
Right. And we can't just use blanket statements saying, well, we studied this, so it means all estrogens act this way and all progesterones act this way.
Yes.
In fact, that was one of the major messages from the WHI was the progesterone versus the progestins, those being the synthetic version.
Yes. Yeah, it's interesting. Yeah.
Exactly. So then in addition to here, patients asking about bioidentical and synthetic, then they also say, well, I guess all bioidentical hormones then come from a compounding pharmacy versus my regular pharmaceutical place.
Mm-hmm. It's so, these are all the questions I get too. Yeah, there is a myth that you have to, pay a lot of money and go to a compounding pharmacy to get a good quality bioidentical hormone or body identical hormone. And that is simply not true. Like we have pharmaceutical versions of estradiol and progesterone and testosterone, at least for men, that work very well. We have compounded versions. And I think it's important for patients to understand that they both work, that there are some instances where one is better than the other, probably for some people. Like if you have a sensitivity to, certain things that are in the pharmaceutical version, like if Prometrium can have peanut, I think it's made from peanut oil or something, then maybe you wouldn't want to take that. You would get it compounded. And I think it's important to work with doctors who are comfortable with compounding pharmacies, even if they don't use them for every patient for all things, because there are, those instances where you just don't tolerate the pharmaceutical version. But for most people, the pharmaceutical version works great. And it's oftentimes covered by insurance, which is fantastic.
Right, exactly. And again, it's what the same feeling and the same message as not vilifying one type of hormone over another. There are plenty of options at your regular pharmacy you may work with, but you may choose to use a compounded version, and that's acceptable as well. And as
Totally.
long as we are monitoring you and getting the proper outcomes, you've got a lot of options there.
Yeah, I really dislike I dislike it when doctors get, say don't use compounding pharmacies, they're unsafe, because
Mhm.
that's just not true. And they're unregulated, which is ridiculous. They are regulated. They have entire groups that regulate them. I mean, are some better than others? 100%. And you want to find a good one, but they are not unregulated. But I also think it's ridiculous to say that we're not going to use big pharma. We're not going to use anything with pharmaceuticals bad. Like that's also very close-minded and also just completely wrong. Like there are a lot of good drugs out there. So you have to be smart. Like just use common sense, be in the middle, and be open to all of it.
Exactly, exactly. And having your physician have a relationship with their compounding pharmacies. I mean, I'm sure you do in your area. I know the compounding pharmacies in my area. I speak to the pharmacists regularly.
Yeah.
So
Yeah.
I have the ones that I can say, I want you to go to these pharmacies because I know that they produce quality product. I'm familiar
Yes.
with them. I mean, sure, we could use any old compounding pharmacy, but I want to know what you're getting.
100%. And you also get to know things like, well, what are the flavorings that they're putting in their troches? Like I heard there was a pharmacy recently. So troches, as you know, they go under your tongue there, they just dissolve kind of slowly. It's one of the options that you can take as a sublingual for these hormones. And I was looking at one of some of the flavor lists at the list of flavors, cherry and grape and lemon and all these things. One of the flavors was chicken pot pie, which I thought was so funny. I don't know why. But I was
Wow.
like, what kind of pharmacist is like, you know what women want?
We
They want to
missed
be
it.
sucking on a chicken pot pie for 30 minutes.
Yeah. Because I'm sure menopausal women are craving chicken pot pie and they just
They're
wish they could
craving
get it
it.
in
They're
their
craving
troche.
it. Anyway,
That's
I thought
crazy.
that was so funny. I'm gonna have to try it at some point and just see what that
Just to
tastes
see what
like.
it is. Exactly. And actually, that's compounding. Pharmacists can be really helpful if you are using vaginal products of medication because sometimes you are sensitive to, it's called the vehicle, the cream that the
Hmm.
medication goes in. But the pharmacists are so knowledgeable about, well, let me change this and let me try this base. And being able to work with the pharmacist has been invaluable in this field.
Yeah, I think that's so true. I think a lot of women for like vaginal estrogen, they use the pharmaceutical product, which is great. It works fine, but a lot of people have problems with it. Like it's irritating to people. But there's a Lage is one. I don't know if you use the Lage base, but it's one of the bases that the pharmacist can use for the vaginal product. And it not only is it irritating, it's like hypoallergenic, but also it has this interesting property where it goes in, it like microemulsifies and it interacts with your vaginal mucosa to help it kind of stay in there. So instead of like just falling out, like when you stand up, it kind
Like
of stays
blob.
inside better. It's like you avoid the like blob effect when you wake up. So just things like that. Like it's always good to ask your doctor and then even the pharmacist, like, could this be better? Like I'm having this problem. Is it always, do I have to have it? Or could it be better? Like, can we change something to make it a little bit more tolerable?
Right. And, as physicians, it's lifelong learning for us too. My patients always ask me, this is bothering me. Can it be better? And sometimes my answer is, I don't know, but I'm going to call my pharmacist and ask, and we're going to talk it out and see if there's something I'm not aware of. I
Every
love
day. I learn something. Every single day, I learn something new.
right. And you can only do that by having good relationships with all the people caring for your patients.
Yeah, 100%.
So, one of my favorite questions that I get from people is, should all women start hormone replacement therapy? Why would I start hormone replacement therapy? And I have my own thoughts on how I like to answer that, but I really would love to hear from you what you get.
Yeah.
Obviously, you get patients completely naive coming in saying, I'm not sure if I should start hormone replacement. What are the benefits to me? What are the risks? How do you answer that question?
In perimenopause, I tend to treat women who have symptoms. So if you don't have symptoms, if you feel great, I still want to have a relationship with you. I want to make sure we're following you closely because that's going to change eventually. You'll eventually not be in perimenopause. But if everything is perfect, I'm not as pushy, if you will, on saying like you need all these hormones. However, as women get into menopause or pretty close or are into menopause, in that transition, I do at least recommend having the discussion with your doctor. Now, some women are very much against it for whatever reasons, and that is completely your decision. I'm not going to push you. Some women, because of a breast cancer or other hormone cancer history, whether that's recent or distant, maybe they aren't candidates, maybe they are candidates, and it's just a matter of discussing. But the discussion should be happening. if I had my way in the world and we could give these hormones to everyone, I would have all women on hormones starting at least in menopause.
Mhm.
Because I think that they're so protective. Not, I mean, even if you don't have symptoms, I think that they're so protective for heart and bones for sure, probably brain, for sure for pelvic floor, muscles, all of those things. But unfortunately, the universe has not asked me, and we
Right.
only have about 4%, I think, of women in the
So
50
low.
plus age group are actually currently on hormones, which I think is a pretty abysmal number.
Hmm.
What,
Absolutely.
what about you? What is your feeling on it?
So my feeling is very similar. I usually talk to patients about the immediate benefits of hormone replacement and the long-term benefits. And this, I feel the same as you. If you're not symptomatic right now, then there's no real immediate benefit from hormone replacement. I can't make you feel better if you're not complaining of a symptom that I can
Right.
improve. So if you're younger, you're not yet through the menopausal change, I want to educate you about what's coming because I think education of women in this time of life is completely lacking. But as women pass menopause, now they're entering that second half of their life where chronic disease is just going to start to pile up. And I think one of the most important tools in their toolbox to prevent chronic disease is proper hormone balance. So I agree. I would love also for every woman to have access and be on hormone replacement, properly monitored, and whatever route works for her and however she feels great on it. But you're right, that's just not going to be anytime soon the reality.
Yeah. I mean, and unfortunately, a lot of women, I get messages every day from women who just don't have access. Like they want to do it. They've been reading, they've been researching, they know what's going on, but their doctor doesn't know, doesn't understand it, thinks it's a bad idea. They don't have anyone else in their world that they can do it, or maybe they can't afford to go to see, someone who is a cash kind of private
Right.
pay concierge doctor, someone who's outside of insurance, which oftentimes doctors, do hormones are because we like to be able to spend time with our patients and not have the insurance companies kind of
Right.
lurking over our heads. So, I totally know I feel for all of these people because I can't imagine how hard it must be to not have access, but to know this is something that you're interested in doing.
Mhm. Exactly. Especially if you have some information about the benefits, the health benefits for sure. So,
Yeah.
the immediate benefits of improving your hormone balance. I think people know about hot flashes and night sweats, and some people feel that's all menopause is hot flashes and night sweats. But there are so many other symptoms that women experience going through the menopausal change. What are some of the other symptoms you see hormones improving during that time frame?
Yeah, you're right. There's so many things. I mean, joint pain, like muscle pain is a big one. I hear from patients and me as well. I'm 49, so I'm kind of like in this like middle zone. Like there's so many days that I wake up and I'm like, did I compete in like an Ironman yesterday and not know about it? Like, why is my entire body so sore?
Yes. Oh
So
my
like that body soreness, joint soreness, all of that is very common. Dry skin, itchy skin, dry ears, dry eyes, like all of this weird, like it's like we're drying. Estrogen is so funny. It likes to hold on, it like helps hold on to water. And so which is why when you start estrogen, sometimes in women, they get a little bit like water retention and they're like, oh, I'm a little bit bloated. But because estrogen is like wants water to come towards it. But it's that's why estrogen in your skin keeps your skin so hydrated and it keeps it plump and youthful, and your joints, like all of these things. So a lot of times we see this like drying out of
God.
like different
Head
systems,
to toe.
drying out of the vagina, drying out of the eyes, the joints, like so which is sad. And then a lot of just weird stuff too, like mood changes, irritability, brain fog is a big one. Like all of a sudden, like I can't think of like that person's name. Like I know their name. They're like my friend. I can't think of their name. Um, weight changes, shifting of weight, like maybe you didn't gain weight but it's more in your belly and it's in places that it wasn't before. And then of course it changes in libido. I just did a talk just before this
Mhm.
about sexual health in menopause, and it's about 30 to 50% of women during the menopause transition just lose interest in sex, and some of them come back to it but most don't. And so 30% of people over 50 of women aren't sexually active, and that's a lot of that's because of hormones too.
Hmm. Absolutely. And I think a lot of people don't realize, both patients and even physicians, all of the symptoms that go along with the menopause change and that are attributable to these hormones that are waning and fluctuating all over the place. The mood changes, especially. I mean, it's very common for a perimenopausal woman to go to her primary care with mood changes, anxiety, depression, whatever, and to be prescribed an antidepressant because that's what's at their fingertips. What are your thoughts on that?
Oh, I feel so bad about that. I just hate it so much. What, SSRIs, like for use, for instance, and I just learned this yesterday, actually. I was looking up SSRIs for hot flashes. So a lot of doctors will give them for hot flashes too. It's, it is, I think even one of them is FDA approved for that. But they only reduce hot flashes about 10% better than placebo versus like estrogen, which, is like 60, 70, 80% better than, it actually works. So they don't really help with hot flashes. They, don't really help with depression most of the time. And I didn't know this. I didn't know that SSRIs increase bone turnover, and that, women who are on SSRIs within 2 years, 1 or 2 years, they tend to lose 4 to 6% of their bone mass,
When
which
they're
I
on
had no idea.
time frame, when they're losing bone mass from poor hormones,
They're already losing bone mass, and you give them something that is making their bone loss worse,
even more so.
instead of something that works better and actually builds their bones, which is estrogen. It's completely crazy.
Right. Right. And part of that, I can't totally blame them because I know we don't get any education on this or any significant education, I should say, about hormones in medical school or in training programs. I mean, I'm OBGYN trained. We learned about the normal menstrual cycle and the loss of hormones at menopause, period. Right.
That's
And
it.
that's
That's it.
all. That's it. That's the end of the training. And now ACOG does have some guidelines on, they're starting to move forward. They do have some guidelines about managing hormone replacement therapy, but it's fairly limited to vasomotor symptoms, those hot flashes and night sweats, the genitourinary syndrome of menopause, the drying out of the vagina, the irritated bladder symptoms. It's not looking at the woman as a whole and all of these other inflammatory symptoms because estrogen is so anti-inflammatory, as is testosterone. So
Yeah.
you're
I
just
know. It's interesting though, like even like NAMS, like now the Menopause Society, and they have their guidelines from 2022. I tell women, like if you have a doctor who's resistant to giving you hormones, but like is someone who could, a great way to do it is to print out the 2022 NAMS guidelines, NAMS. And in the guidelines, they say that estrogen is essentially first line therapy for vasomotor, like you said, and genital urinary symptoms of menopause, and to prevent the bone loss that could lead to osteoporosis. And that's the one that if you circle it, circle that and bring it to your doctor, because 50% of women over the age of 50 will suffer from an osteoporotic fracture.
right.
So half of us are going to have a fracture because of osteoporosis. My mom had one last year. So it is coming for you, or at least half of you. And this is a therapy that is approved by the FDA to prevent osteoporosis, and it is in the guidelines by NAMS to prevent osteoporosis. And so, if nothing else, like if we can debate all the rest of it, and there is debate around everything else, but that one piece is not debatable anymore. And I think that should be enough for most doctors to read that and be like, okay, we want to prevent bone loss. Got it.
Right, exactly. Because that would even take all of your asymptomatic women who are going through menopause and saying, well, I don't have hot
Exactly.
flashes and I feel fine. It doesn't matter. You are approaching bone loss and
Yep.
preventing bone loss, just like we want to prevent heart disease and prevent high cholesterol and prevent all these other things that are we know increase as we age. Here is a proven treatment for it. That should be enough, but we know from personal experience, I'm sure, it is not. And unfortunately, a lot of docs still live in that fear of the post WHI time when there was a lot of misinformation and hormones are bad and hormones cause cancer, or they need to be stopped after a certain number of years or after a certain age, which are false. And even those statements are all now supported, right, by NAMS as well. Yet everyone keeps up with that if it's not in their realm.
Exactly. My mom, who is she's like 78, not 79. She broke her hip a year and a half ago. She was, she's one of the women who affected by WHI. She had to stop her estrogen. She went more than 10 years without it. I actually ended up putting her back on estrogen about 2014 when I started learning about it. Right. So she'd been taking it for a few years, but she's thin and Caucasian and high risk. So she broke her hip, but she was on estrogen. And when she was being discharged from the hospital with her hip fracture repair, her doctor was reviewing her home medications with her. And he goes down the list. He sees estrogen. He takes a big red marker and marks through it and says, "You don't need this anymore."
After a fracture.
I was like, on what universe does this person not need estrogen?
Yeah.
Of course she does. And of course, and unfortunately, I wasn't there at the time. I had to come, I was out of the country, but I came back a few weeks later. She'd been off of her estrogen for several weeks because of this. And she's insomniac. She can't sleep. She's getting up to go to the bathroom 5 times a night. She's having urine leakage. She's having to wear diapers. Like, it is awful. And not only did he stops her estrogen and doesn't tell her even, you're going to have all these symptoms from being off of it now. And so luckily I put her back on it. She's fine. But it's just so misinformed, so much sad misinformation out there.
Right. And, as physicians, we talk all about informed consent. You're going to give a patient a new medicine or a therapy. You need to give them informed consent. What are the benefits? What are the risks? What are the alternatives? But I am a huge proponent of the negative informed consent. So what are you facing if you choose not to do estrogen? And that's kind of what you're speaking to. You have every right to choose to live half your life without your hormones. It's your body, not mine. But it's my job to tell you what you might be at increased risk for by choosing not to take a medication. So that negative informed consent, I feel like, is constantly missing. And if patients heard that, it's almost a no-brainer. I mean, the osteoporosis alone is one reason, but the benefit to heart and the benefit to skin and mood and sexual health it's so overwhelming.
Yeah. Agree.
To have that negative informed consent for all menopausal women, they have to sign off on it.
I like that. I love that, actually.
Have increased heart disease and fractures and a crappy quality of life for the next.
Well, and not only that, like, we should be, we can sue doctors for like having bad side effects from medications. And, we should be able to sue doctors for not telling us the things that can happen if we don't take their recommendations. Like, it's a whole new kind of suing of doctors that we can do.
Exactly. Well, I mean, I remember hearing that, we order mammograms all the time to screen for breast cancer. And I think there was a successful suit where a physician had ordered a mammogram, the patient didn't get it, and the doctor did not follow up and didn't specify to the patient, without a mammogram, you might have breast cancer and die, but we could pick it up. And the patient did get breast cancer and successfully sued because she said, I didn't realize I could get breast cancer if we weren't screening for it. And it just makes my head go like this because I'm like, well, we don't just do tests for no reason. We are looking to prevent disease in you. So now if my patient misses a mammogram, she gets this letter, and it is kind of a little nasty letter that says, hey, you could have breast cancer and die without this test. And some of my patients are angry when they get it. And I have to go through this explanation of why they need to get a letter, because it's now my responsibility to follow up when you don't, meet guidelines.
Yeah. I mean, I think that a lot of that goes to like just patient responsibility, person responsibility. I do think that in a lot of ways, medicine has shifted so much. So like, patients think that their doctor is going to do everything for them. All I got to do is go see him once a year. They'll fix me up. Like, I don't have to do anything myself. I don't have to eat the right things or exercise, or like, I can just miss appointments, like whatever. I don't have to do anything. And this is, by the way, this is not most people. Probably people listening to your podcast are not these people. But I do think that we need to get back a little bit to like, your health is your responsibility. And yes, your doctor's there to be like your co-pilot, and they're there to help you and to guide you. But ultimately, no doctor can make anyone healthy. We can't prevent disease. We can't even really treat it if you're not on board. And so it's so important to take ownership of that and not just, lay it at the doctor's hands and be like, here, fix me.
Exactly. Such a partnership, because even if we do prescribe a medication that is the right medication and we know will benefit, I'm not in your house every day putting that pill in your mouth or putting that patch on you or applying your cream. Right. I mean, there is those good habits, and I'm certainly not there, helping you choose every meal you eat or choose whether to work out or not work out. I can provide the information and the guidance, but there's patient responsibility after that I agree we've gotten a little bit away from, for sure.
Yeah.
Yep. So what are some of the fears then that you hear both from patients and from providers about the risks of hormones? Because the risks, in my opinion, have just been so overstated, and we're trying to get people to understand that, but it's probably a conversation you have all the time.
I mean, the biggest one is always breast cancer. I'm sure it's the same for you. Everyone's afraid of breast cancer from estrogen or even progesterone. And so that's the number one fear I hear. The second one is probably they're concerned about blood clots and heart disease. I still hear that quite a bit as well. And heart disease, meaning heart disease and stroke, like cardiovascular disease. So, and those are the real, I mean, some people are afraid of like gaining weight or things like that, but most people who don't want to take hormones, either whether it's doctors who won't prescribe them or patients, breast cancer and cardiovascular disease.
Right. Yeah, exactly. And what does the data really show us about breast cancer and cardiovascular disease?
So the breast cancer data is interesting because we have some observational studies, which observational studies I describe, and I know that you know this, but it's kind of like being at a salad bar and watching the people go through the salad bar and saying, okay, I wonder if the people who choose salad end up healthier,
right,
versus the people who choose something else.
Mm-hmm.
And you don't influence them at all. You just watch. And then later on, you go back and say, okay, well, the people who chose salad, they ended up healthier, but you don't know what else that they were doing. Like, you don't know if they were kind of people who would choose salad because they're also running 4 times a day and they have low stress, like you don't know anything else. But we have a lot of observational studies that have shown a pretty slight still increased risk of breast cancer associated with use of estrogen or progesterone, in some cases, progestins. And so that's where a lot of the fear comes from, is some of these are pretty big studies, but have shown maybe 30% increased risk of breast cancer associated with the use of these things. However, when we look at the randomized controlled trials, including the Women's Health Initiative, including 9 other smaller randomized controlled trials, all of which use oral estrogen, either synthetic oral estrogen or oral estradiol, there is actually a reduced risk of breast cancer in women by about 22% who use estrogen by itself without that synthetic progestin.
Right.
And so the studies now, that a lot of people in this space are like, well, maybe the progestin was the bad guy. It probably definitely wasn't helping. Like neither of us use these progestins anymore, the synthetic progestins. And part of it is because in the Women's Health Initiative, this is part of why they stopped that study, is that they were seeing an increased risk of breast cancer. But even with the progestin group, it was not that much. I think it was 8 increased cases per 10,000 women years or something. Like, it's just a small amount, but estrogen alone does not increase the risk of breast cancer in the randomized controlled trials. And it probably decreases the risk.
Right. It's amazing to me that the estrogen causes breast cancer made the headline, but not the other part, which is the estrogen only arm of the WHI decreased breast cancer. And that's even using that synthetic hormone, which maybe is not the best option, right? Maybe there's a better option, but even not using the best option, breast cancer went down. And yet we're still here talking about breast cancer and estrogen. It's kind of crazy.
Yeah. And there's so many, there's a lot of flaws with that, like, with the control group and the placebo group. And there's a lot of people who kind of picked it apart, but nothing, the estrogen only group, there's no question that risk went down. And I think it's interesting because I've read a lot of, I'm sure you have too, like there's a lot of like mechanistic data where if you put estrogen on a breast cell or on a cancer cell, you see like expansion of the cell, like you see proliferation. It's like, oh my gosh, estrogen really is bad. Like, there's a lot of data that shows that kind of stuff. And so isolated like that, it is possible that, that estrogen isn't great for breast cancer cells. And we know, people who have breast cancer, like estrogen can be like gasoline in the fire, but but you have to look at the whole person, because estrogen isn't just working in that little petri dish in a person. Estrogen is doing so many other things in your body, many of which are positive when it comes to to cancer prevention. Many are reducing your visceral fat and reducing inflammation is going to be helpful for preventing cancer. Keeping your blood sugar down is going to be helpful. Like, all of these things. So you have to look at not just what's happening in a petri dish or, in like that sort of mechanistic data, but like what's actually happening in a whole person. And in that whole person, is estrogen more beneficial or not beneficial?
Right. And also speaking to the fact that estrogen doesn't take a normal breast cell and turn it into a cancer breast cell. That change already has to happen, right? That's occurred because of DNA breakage, and we know how cancer starts. But once it happens, yes, in the petri dish, throwing estrogen on there may proliferate or make those cells grow. But I'm always making that clear distinction for patients, is that the estrogen doesn't take your normal breast cells and turn them into cancer breast cells.
Right. Yeah, and I just read a paper. It actually hasn't been published yet, but it's about progesterone. It's a whole. It's in the oncology literature talking about, well, maybe it's not estrogen that's the problem. Maybe it's progesterone that's the problem.
Right.
And again, there's in some of these biggest big observational studies, they've shown that women who are on progestins, most of them were progestins, although some were on progesterone long term, have an associated increased risk of breast cancer. So now some of them are saying, well, maybe it's the progesterone that's the problem. Honestly, I don't think we actually understand I think there's so much interaction with all of these hormones. I think obviously genetics plays a role, obviously lifestyle, like there's so many things that are interacting, but so we don't have all the answers. But right now we can say that in the studies, the randomized controlled trials, estrogen doesn't increase breast cancer and progesterone doesn't increase breast cancer in any randomized controlled trials. But synthetic progestins might a little bit.
Right. Exactly. And that probably goes back to the way the normal progesterone, the body identical progesterone, fits into the receptor versus the progestin.
Yeah.
Progestins were developed to protect the endometrium against cancer. And they do that great. They fit in that receptor correctly and they prevent endometrial cancer when you're taking them along with an estrogen product. But they didn't look at the body entirely, the entire person. And the synthetic progestins probably do not do the same job as our body identical progesterone in the breast and other places.
Yeah, exactly. Yeah. And the brain, like progesterone is so important for the brain. What do you tell women who are, about like if they don't have a uterus, they've had a hysterectomy, like how do you use progesterone in those, or do you not use progesterone in those?
I use progesterone for everyone.
Yeah.
Because
I do too.
Right. Even if you don't have a uterus, I mean, it's mandatory if you have a uterus because obviously it has the protective effects against endometrial cancer. I love progesterone for the brain, the calming effects in the brain, the balancing of the cortisol, the benefit to help sleep. If you're taking oral progesterone, usually we dose it at night because it has that nice relaxing, sleepy side effect without making you feel hungover. Some people are actually too sensitive to that and they can't tolerate that nightly progesterone. We have to make it in a different way so the progesterone does not have a sleepy side effect. But most of my patients love it. And even if they choose to not start estrogen for whatever reason, I may start them on progesterone alone. And I'll say, well, let's do this and get you sleeping better and get your brain better. And then we'll see how we go from here.
Yeah, I'm the same. I love it. I think it's very calming. It's like the yin and to the yang of estrogen. Estrogen's like super like to the different tissues. Like it's building them up. It's excited. Right. And then progesterone's like, no, let's calm down a little bit. So I think it's helpful.
Exactly. I mean, progesterone by its very nature is actually anti-cancer. It's a hormone that helps cells differentiate, which means turn into what they need to become, and its cancer cells stay undifferentiated. So just by its very nature, it's helping to push cells away from cancer rather than towards cancer. So that in and of itself is very reassuring, I think.
It is. And I think that, I think that this idea that progesterone is contributing to breast cancer is probably not true, because we know that it can be apoptotic to breast cancer. Like it can help destroy breast cancer. But we'll learn more as we go, but I'm not at all worried. I think progesterone is a fabulous tool.
Right. Absolutely. So that's great information for patients who they themselves do not have breast cancer. And that also applies if their family members had breast cancer. Hormones do not increase your risk of breast cancer if your mother had it or your grandmother. But what about patients who've had breast cancer? Does that negate them from receiving any type of hormone replacement therapy?
These patients are so hard.
So difficult.
And I know that there's so many of you women out there who are these patients, and it is so hard. If you have triple negative breast cancer history, then there's no reason you can't have hormones. And this is most oncologists are okay with that. The ones that are difficult are if you've had a hormone, ER positive breast cancer in the past, which is most breast cancers. And I will say I have a hard time giving these women hormones if their oncologist is vehemently opposed, which most of them are. I used to say like, well, as long as we waited 5 years or so, it's probably okay. Because we have a lot of studies that show that the hormone therapy in these patients does not increase cancer recurrence risk. There's only one study, really, the HABIT study, which showed that giving these women who've had breast cancer, giving them hormones, that increases their recurrence risk. And that, it did show an increased recurrence risk by about threefold. But there have been many other studies, like 20 of them, that did not show an increased cancer recurrence risk when giving hormone therapy to these patients. However, it's difficult. And I was talking to a breast oncologist last week about this, because she's like, we spend so much time, like we spend all of our time trying to figure out how to get estrogen down and away from these women. Like we're trying to protect them from estrogen. And
Right.
so the idea that, that doctors that later want to just give it to them. And, she said it's not just 5 years. Like there's a lot of these women will get cancer at 10 years or more. Like it'll come back. And so the idea that you should just not give it for a few years, is hard. I think they're very difficult because I don't want the person to get breast cancer, because then if they do, obviously it's bad for the patient. It's also bad for me, and it's bad. The oncologist is not going to understand what happened. So it's a long discussion with every patient, about risk and benefits. Now there are some tumor genetic testing that the oncologists do, to look and see if a patient is a good candidate for aromatase inhibitors long term. And that testing might be useful to know, like, if someone's maybe a better candidate for hormone therapy versus not. That sort of, it's called the BCI test. We're not using it yet, but I don't know. I struggle a lot with these patients.
It's a challenge. And I never want to set a patient up to feel like their doctors are pitted against them, where their
Exactly.
oncologist is just saying, absolutely no, you can never have hormones again in your life. And then their hormone doctor is saying, well, let's open this door and it's possible and you could use hormones. And then very often the patient just feels so caught in the middle, and they're getting pulled in both directions and they don't know how to make a decision because they also don't have all the data at their fingertips like we do. I mean, we certainly try to educate them, but there's no way they could have all the information, to make a clear decision.
Yeah, I think it's very, very difficult. I know certainly I've had women who I've started on hormones if it's been, more than 5 years usually. And, if their doctor doesn't mind and is like, go for it, then that's an easy decision. But if it's a doctor who's really much opposed to it, the woman is very much in favor, then we have to sit down and say, like, this may increase your risk of recurrence. And
Right.
so, it's a very frank discussion. But, the truth is that these women who have breast cancer, many of them die of heart disease, not breast cancer. And so we have to have that discussion too. Like, what are we most afraid of? What are the things that we think are, and even if you're not giving them hormone, if you're not giving systemic hormones, I definitely recommend the low dose vaginal estrogen for
Right.
sure. Like that's easy. Those women should first, every woman over 50 should have access. This should be like on your bedside table.
Right. That should be
Every woman over
natural.
50 that should have low dose vaginal estrogen. And if we're not going to give them systemic hormones, we should still be very specifically addressing all of the different systems that are declining because they don't have those hormones, like paying very close attention to osteoporosis risk and preventing that, just being very vigilant with these women about how do we prevent disease. If we can't give you estrogen, what else can we do?
Mm-hmm. Exactly. And I know we can't answer that question if you've had estrogen positive breast cancer. What is the risk, right? Taking estrogen will increase my breast cancer risk. There's no one easy number that we can
No.
answer that. But I think we also have to look again at the whole woman. Are you obese? Obesity puts you at risk for recurrent cancer. Are you smoking? Are you drinking alcohol? All of these other things that actually have a very well-known increased risk
Yes.
of breast cancer. So I can't give you that number for hormone replacement therapy, but I can give it for the amount of alcohol you're drinking or the amount of cigarettes you smoke or the amount based on your BMI. And
Yeah.
those are all so much more easy to modify than having this very complicated discussion about hormones,
Yes.
even though I agree. I think a lot of women, if they're given all the information, will say, I will choose an improved quality of life and a reduction in my osteoporosis risk and heart disease risk, even though I know I might be taking a small chance that I'll get a recurrent cancer. Like, I'll deal with that if that happens, but I would rather have a much more healthy and satisfying life in the meantime, if that even does happen at some point.
Yeah.
Yeah.
Agree. It's a very underserved population of women. I think that, I wish that the oncology community, and I know they do a great job, and I'm not dissing them at all. I just wish that there was more research into what else, like who would benefit from estrogen and who is it going to hurt after the fact.
Exactly. Taking not lump once again, not lumping all those breast cancer patients into one pot and just putting them all into the same group of they can't have hormones, but sorting them out and saying some of them probably can safely use some hormone replacement. Others, maybe the risk is too high and we choose not
Yeah,
to proceed with it. But we don't have those answers right now.
exactly.
That is great. Well, is there anything else that you would want your patients, if there's a couple of things you would want your patients to know about hormone replacement that they just can't live without knowing, what would those pieces of advice be?
I think that there's usually a good solution for most people. I know sometimes it takes some time to work with your doctor. It's not like you go to the doctor, you get a pill and you're done. It oftentimes is a process over many months, even a year or more, to find like the right form of hormone, the right dose of hormone, the right combinations of hormones. Like just be prepared for it to be an ongoing adventure.
Just like aging.
It's an adventure. It's an adventure. You're on a journey. You're learning as you go. And of course, a lot of lifestyle factors, of course, play into this as well. Like sometimes, even your tolerance to the hormones are affected by, things like your insulin sensitivity, or if you're overweight, or there's a lot that you could do to make these hormones work better and feel better as well. And just, continue to ask your doctors to do better. Because I think that if we continue, if women in general continue to go to their doctors with good studies, with guidelines, and say, I would like to try this, I would like for you to learn about this, I would like to do this, then we'll get more and more medical providers that are, choosing to learn about this kind of medicine. And it's not fringe, it's not wacky woo-woo medicine. Like this is legitimate evidence-based medicine that we need to bring to the mainstream. So women can start, just advocate for themselves and for their doctors to get themselves educated.
Oh, that is so important and such a great message. And women don't realize they have to advocate for themselves, but we provide our patients with lots of information when they'll say, my PCP had a question about this or was fearful of this. And I'm constantly writing letters and talking to PCPs directly. I'm more than happy to speak to any provider who wants to talk about hormone replacement therapy, but I'm also giving that information to the patient and saying, not only can you read this, but the next time you have an appointment, you can show up and show them these things and show that you are getting really excellent care. And it really emboldens the patient, because patients don't want to go against their doctor. They want to assume that their doctor has their best interests at heart. And there's no doctor out there who wants to harm their patient. I mean, it just doesn't happen. We all do the best for our patients, but I just think some physicians don't realize that withholding that is actually a form of harm. Just they're not aware of that.
Absolutely. Completely agree.
Great. Thank you so much for spending time with us today. This has been wonderful.
Yeah, this has been so fun. I'm glad that it's good to talk to someone so like-minded, so similar in approaches. I love it.
Yes. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.